Marnie Nabudni, and welcome everyone to Grand Rounds for this week. I'd like to acknowledge that we meet today on the lands of the Kaurna people. I pay my respects to their elders, past, present and emerging. I extend that respect to any Aboriginal and Torres Strait Islander people present today. Before I introduce our speaker for today, I'd just like to make another announcement, and that is that we have upcoming the Guha Prize. We are very keen to receive nominations, and there are a large number of candidates, as you can see on the screen here, who are eligible for this esteemed prize, which is about excellence in training for physician training. These are the candidates who've recently passed the clinical divisional clinical exam for physician training. And if you've got anyone that you think is an outstanding candidate, could you please send your nominations to Alice O'Connell? We'll be announcing the winners toward the end of November at Grand Round. So thank you very much. So my next task is to welcome back one of Grand Round's favourites, someone we've had here before. We've got Associate Professor Arthas Flabouris from our ICU, and of course he's going to talk more about deteriorating patients. This time it's a really clinically applicable topic, I reckon. My patient has had a MER call. What to look out for next and longer term implications. Thanks so much, Arthas, for joining us today.
Thank you, Jo. Thanks for the invitation. All right, thank you everybody. I'm just fire up the presentation and get going. Oops, let's not jump too far down into it. Nice. All right, good. So I've talked a little bit about the MET over the years and at the Grand Rounds, and I see this is another evolution of that journey of the way we've sort of kind of described MET. Talked about MET when we first introduced at the Royal Adelaide. Talked about MET after the introduction of the current MER service as we know it. And now I want to sort of talk about MET beyond that period in time. So we know from the literature that patients who've had a MET call, they've got a high ICU mortality, a high hospital mortality, they've got a longer length of stay. They're generally elderly. Median age is somewhere in the 70s, and the elderly are more likely to have a MET call. They've got a higher MET dose than those who are younger. They're more likely to have changes in goals of care. Again, their mortality is high. And the patients who trigger MET calls, according to the literature, have become older over time. They're also fairly comorbid, and they've got a median Charlson index of 2. I've got a Kaplan-Meier curve from the original study that reported on the Charlson index, and essentially, if you've got a Charlson index of 2, your 10-year survival is somewhere just under 20%. And with MET patients, they're said to have 20% of them got a Charlson index of 3 to 6, which then reduces their long-term survival even more than that. The triggers have also changed over time based on what we know from the literature. The physiological triggers have increased in their prevalence. Things like decreased GCS, hypotension, and tachycardia have become a lot more prevalent as triggers. And then repeat MET calls are not infrequent. About 20% of patients have repeat MET calls. Those patients that do have repeat MET calls, they've got a higher, longest hospital stay, they've got a worse hospital mortality, greater odds ratio of an ICU admission, and they tend to be elderly. Limitations of therapy have been associated with MET calls for a very, very long time. There's a variable rate at which different MET systems institute limitation of medical therapy, but can range up to about 30% of calls. A lot of patients, though, still have prior existing limitations of therapy at the time of the call. So the association of limitations of therapy with MET calls remains strong. And again, if you reflect back on what's there in the literature, activity's been increasing. Getting increasing number of calls. We think that's a good thing. We're not quite sure yet, because we know that there's a bit of a dose response curve. We don't know where the sweet spot is with the dose response curve, and we also don't know if there's a ceiling effect with the dose response curve. So whether the increased number of calls is a good thing or a bad thing with respect to imposition of resource consumption, the literature is a little bit unknown in that sort of area. So with all that burden amongst patients, it feels a little bit like this. It feels a little bit like Atlas. Even though he was skilled in philosophy, mathematics, and philosophy, he lost the war with the Olympian gods and was banished to hold the sky up for the rest of his life. FYI, this is just the most oldest sculpture known for him. If you dig a little more into the legend, he was either petrified by the head of Medusa, or he was tricked into continuing to hold the sky by Hercules. What's our experience? Our experience is very early on with introduction of the MET system. It did reduce cardiac arrest, it was associated improvement in hospital mortality at the Royal Adelaide, and a reduction in unanticipated ICU admissions. Particularly the cardiac arrest and the association with hospital mortality has been ongoing. The bit about reduction in unanticipated ICU admissions, it seems to sort of kind of pad it off a little bit. We've also sort of shown that we can limit our escalating activity with introduction of the new MER service. We can improve on those performance measures with the new MER service, and potentially we can impact on repeat MER calls with introduction of the MER service. So considering of what the literature tells us and what our experiences are, there's a few little contrasting elements, but more significantly, there's evidence that that we can improve on some of that burden that's documented in the literature. So we sort of set out to understand not just the short but the longer term implications of the MER call on our patients, because that will help us in terms of understanding the patient care that we deliver, the clinical implications of the MET call, as well as some of those discussions that are so important when we have with our patients at the time of a MET call. And our study looked a little bit like this. We looked at the MER data from July 2013 right through to June 2020, and then matched it with death registry from 2030 to June 2021, so 1 year beyond the MER data. For our MET calls, we know that we respond to inpatients, outpatients, visitors, and staff, so we subdivided them. And for each of those groups, although it's not illustrated here, it's only illustrated for the inpatient ones. For each of those groups, we looked at whether they had a repeat MER call if they died. If they died, did they die at the time of the MET call? Did they die during the hospital stay? Or did they die post-hospital discharge? And if they died post-hospital discharge, where was that death? Did they die at a private location, readmitted to the RA and died at another hospital, or did they die in nursing home? And that effectively sort of kind of shows you the flow of what we sort of kind of looked at. So let's have a little look at the repeat MER call part of it. About 40% of the patients had a repeat MER call over the study period, which was a little bit just under 9 years. Inpatients and outpatients to a similar proportion. And surprisingly, visitors and staff members had repeat MER calls, but obviously at a much less rate. With the inpatients and the outpatients, remember it was over a 9-year period, so you could have had a MER call as an inpatient and then have another one as an outpatient maybe a couple of years later, and similarly with outpatients. But regardless, 40% of the whole population had repeat MER calls. And the timing of it was also interesting. Most of them, 50% of them happened within a couple of days. But 25% of them happened beyond 25 days. So there are patients who have a MET call at one inpatient presentation, who might get discharged home, come back again, and they'll have another MET call. So it indicates patients are kind of prone to MET calls. To further illustrate that, about 40% of the patients had a MET call within the first 24 hours of their first MET call, and 10% of those were admitted to ICU. 10% happened between 25 and 48 hours. Fewer of those got admitted to ICU, and more than half had it beyond 48 hours. And even fewer of those were admitted to ICU at the time of their second call. The patients who had repeat MET calls compared to those who didn't were of similar age, more likely to be males, more likely to be admitted to ICU, particularly if you had MET calls sooner rather than later after your first MET call, but they also had a higher mortality. Multiple calls tended to be after hours, but the pattern across the days of the week was not different. And that after hours ratio is not all that great. It's sort of 48 to virtually 47%. So let's have a little look at the hospital and post-hospital outcome. Just a little bit about demographics. The vast majority of our group, as we know, based on our case mix from our MET calls, were inpatients. So 90% of the study population were inpatients. Inpatients were older than staff and visitors, as you would expect. The gender varied a little bit amongst those groups. And at time of the MET call, more inpatients were likely to die at the time of the MET call than outpatient staff or visitors. The mortality at the time of the MET call was quite low. It's just a little bit over 1% within that patient cohort over that 9-year period. In terms of hospital mortality, inpatients, it was about a 13% overall hospital mortality, and obviously much less for outpatients and visitors, and none of the staff members died in hospital at the time of that first MET call. Going a little bit beyond that, as we mentioned, age, the inpatients were older than the other groups. Overall, if we look at the census date being July 2021, just over 50% of inpatients were alive at that time. And only almost all staff members were alive at that time, and 3 had died by that period. And about 94% of visitors were still alive around about that time. Those that were alive, the median age for inpatients, if you remember, the median age for the MET call is in the low 70s. Median age of those that were alive at the census period was less than that, so 69. So it's the younger ones that tend to survive, as what you would expect. But interestingly, the age at which they died was 79 for inpatients. And if you compare that to South Australian life expectancy, the life expectancy is said to be about 80 years. So it's not too far off there. Where did they die? Most of the deaths, 3/4 of the deaths, actually occurred post-hospital discharge. So if we just look at hospital mortality when we're tracking our MET patients, we're going to miss 3/4 of the patients that died following a MET call. You'll see at the far this side over what would be over your right-hand side, with respect to the general population, the location of their deaths as given by the death registry. Somewhere near 20% of the general population die in a private location. By private location, I mean home or a public area. In contrast, half of inpatients who have a MET call die in a private location. Much more of them die following a readmission. And that readmission is either to the Royal Adelaide or to another hospital. Since we're only looking at here patients who've had a MET call within the Royal Adelaide, it's a bit, the sample's biased by the Royal Adelaide catchment space, but nonetheless, about a third of the patients who die after a readmission die in another hospital. What does the Kaplan-Meier curve look like? Essentially, that's the Kaplan-Meier curve that shows for both staff, visitors, outpatients, and inpatients in that descending order. And you can see somewhere around about of inpatients, about 45% of them are alive at about the 9-year mark. Break that down by age. The one over Kaplan-Meier curve over in your top right-hand corner. By elderly, those who are over 65 years old, by sort of kind of the 9-year mark, about 30% of them are alive. And the one over in the top left just shows the different age groups, and the sort of pattern, as you can kind of see, the older you get, the kind of the steeper and lower the Kaplan-Meier curve goes. Medical patients were at greater risk than what surgical patients were, and there's a big differentiation between patients that had multiple calls and patients that had only one call. If you've only had one call, you're about 55% survival. If you've had multiple calls, you're down to just a little bit over 30% survival. Let's look at limitations of medical therapy. 10% of patients had a limitation of medical therapy, with most of them were pre-existing not for resuscitation order at the time of their first MET call. With limitations of medical therapy, I'm only looking at not for resuscitation orders. I'll talk a little bit more about not for ICU and other sort of limitations, but just crudely, it's not for resuscitation. As you'd expect, those that had an NFR order were older, more likely to die at the MET call, more likely to die at the hospital stay, around about sort of 30–40% mortality. But yet again, you know, somewhere if you look down the bottom row, you know, somewhere between 6 to 8% of them were died in a private location, and then the vast majority, as is for the rest of the group, died following readmission to another hospital. So, you know, if you've got a prior limitation of, if you've got a prior NFR order, you have a MET call, you know, there's a good chance that you'll survive your hospital stay. It does impact on your longer term mortality. Again, it's something that's not unusual, but now we have a measure of what that limitation looks like. And if we map it out on the Kaplan-Meier curves, if you haven't got a prior NFR order, you know, again, it's sort of kind of like the 9-year survival is just a little bit under 60%. But if you do, and generally regardless of whether that NFR order was issued prior to the MET call or at the time of the MET call, it's a sort of a similar cumulative survival of just under 20%. So even though it's low, it's you know, it's not substantial. And I guess all of us can make our own value-laden judgment on what we think about that 9-year survival. Breaking it down a little bit more to look what it looks like not for ICU, but I also wanted to have a look at not for MER category. The not for MER category is a fairly sort of kind of recent-y type category. We're starting to do that a little bit more frequently, and I'll show you a graph about that later on. And interestingly, if you get put down not for MER, you will have a very, very steep early mortality, which flattens out a little bit. But you know, sort of even amongst that group, they don't get to the sort of the 9-year mark, but you know, the earliest there they get to sort of about 8 years in terms of the latest survival. Looking a little at the triggers, this graph just shows the mortality associated with each trigger, the 12-month mortality associated with each trigger in the bars, and the line shows the frequency of those triggers. So you know, triggers like cardiac arrest have a high mortality, and fortunately they're infrequent. Some triggers like unattended unattended home team review, worried, don't have a very high mortality and are somewhat prevalent. But then you've got those bits in the middle, and in particular the respiratory ones. And I want to talk a little bit about the respiratory ones again later on. They're fairly prevalent and have quite a high associated mortality. Significantly, if you go a little bit more over to the right, just near the cardiac arrest column, that's where sort of kind of the cardiovascular ones are, the tachycardia and the hypotension. They're also prevalent, but if you notice, their mortality is much less than if you had a respiratory trigger. That's the sort of kind of pattern we're getting at 12 months. When you map that out and break them down to a couple of Meier curves for each of the individual triggers, that sort of reflects longer term as well. If you have a respiratory trigger, and you know, desaturation, tachypnea, not bradypnea, but tachypnea, your longer term outcomes are much worse than if you have hypotension or tachycardia alone. And worried is the one with the better or the best longer term survival out of all the triggers there. Look, it's a busy slide, but I just want to highlight the column over on your left, which is mortality at 12 months. And the order of the triggers is sorted by lowest to highest mean survival. And the mean survival is the second most column in from your left. And the column at the far left is the hazard ratio. And the hazard ratio, I'm comparing it to the Worried criterion, where the Worried criterion is 1, and then the others are, the ratios are based around that. As you would expect, cardiac arrest, respiratory arrest have the least survival associated with them, and then you get your respiratory triggers coming in, your desaturations, your tachypneas, before you start to get hypotension, decreased GCS, and tachycardia. The ones shaded, Worried is in yellow, the ones shaded in sort of kind of that pale orange are ones that have an odds ratio, a hazard ratio that is not significantly different to that of Worried. So if you have a threatened airway, bleeding, bradypnea, hypotension, your odds ratio of long-term mortality is no different than what the Worried criterion is. Whereas if you have a cardiac arrest, you've got 4.5 times greater hazard ratio than if you were the Worried. So if we're going to summarize it so far, repeat MER calls are common, and not just for inpatients, and they're associated with poor outcomes. And they may well be associated with a poorer quality of life. You know, the only quality of life measures we've got with this data is you're less likely to die at home, more likely to die readmission or in a nursing home. And they also reflect a burden that's carried over longer term, and with a slightly abbreviated life expectancy. MER patients are elderly. Most of those die post their hospital discharge after their first MER call, yet about 45% of them are alive at about 9 years, and they're also less likely to die at home. The type of trigger influences your outcome. So Worried, you've got a better outcome. Cardiac arrest, you've got a worse outcome. Respiratory triggers are worse than the cardiovascular triggers. Limitations in medical therapy are fairly prevalent and are associated with or attached to them as significant limitations in longer-term outcome. But having said that, 10% of them, based on our data, are alive at about 9 years, and most deaths occur after the hospital discharge, which is a really important point. So it's important for us to be able to track our patients to better understand the consequences and the label that a MER call puts on them. So based on all of that, a MER call is a clinical marker for short and longer-term burden of health service consumption and mortality for these patients. And as such, I think you need to factor this in when patients have MER calls. We need to include it in things like discharge summaries. We need to look to see whether they've had a prior MER call, because that does put a value, clinical value, on this group of patients. So let's have a look at a little bit of our performance and over time, and what implications have as our service and us as an organisation performing within the MET space, how we can impact on some of these longer term outcomes. So if we look at our outcomes at MER calls, since the introduction of the MER service back at the inception of this hospital, mortality at METs have reduced. More patients are being left on the ward, and not statistically significant, but a slightly less so number of patients are being admitted to ICU. Mortality at 12 months post MER call is improved since the inception of the new service. So that's showing the positive impact that we're having. And if we break that down to sort of kind of where patients might be dying, we have had an impact on whether they die at a private location. Fewer of them are dying at a nursing home. Now that might well be a reflection of the shorter period of the new MER service as compared to the older MER service. A few of them have gone on to get to a nursing home, but we are talking about 12-month mortality. So there is a significant signal there, and more significantly, more of them are dying after the readmission to a hospital, particularly a readmission to the Royal Adelaide in the MER service period as compared to the pre-MER service period. Haven't got a strong explanation for that, but that's what our data is showing us. And importantly, the service has had an impact on the proportion of patients that are having multiple MER calls. And I guess that's part of the aspect of the goals of the current MER service, of following up patients, having an objective of not just responding to calls, but preventing calls from occurring. And how does that compare to sort of kind of longer term outcomes? The 2013 and 2014 are the orange dots and the green dots down the bottom. And then 219 and 220 are the shorter abbreviated Kaplan-Meier curves in the pink and blue at the top. So, you know, looking at this data, there's a signal suggestion there that you know, what we've done so far to date with the MER service is impacting positively on patients' longer term outcomes, as well as their shorter term outcomes that we sort of kind of measure. Age has trended downwards for our inpatient group, and I think that is significant because the outpatient age, the age of our staff and visitors, has remained flat over that time period, and I'm talking about the time period since 2013. So that's an important marker to keep in mind, and there's been trends in the not for resuscitation orders. Certainly, post the introduction of the MER service, patients who have had a prior NFR order are more prevalent. For us at MET calls, we're tending to initiate fewer MET calls at the time of the MET call, but we're encountering more patients that are got prior NFR orders, and those patients that have been labelled as not for MER at the time of the MET call, which is that sort of kind of bottom left-hand curve, is generally pretty flat. The trends go up and down a little bit, but they're not statistically different. Although there is certainly the ones with the pre-existing NFR orders and the NFR orders are MET calls, they are statistically different, and those patterns are significant. So you've had multiple calls. What's the next call? The next call, surprisingly, not always as you expected. I'm just going to show you some data, which is a little bit busy, that I haven't drilled down into quite a lot, but just to be illustrated. So it looks busy, but I just want you to sort of kind of glance on the big picture stuff that the pie graphs tell you. So the top row is the patients who've had a MET call for a desaturation, and the pie graphs illustrate the reason for their second MET call. And the ones on your right-hand side pie diagrams are illustrative of the triggers that occurred within the first 24 hours of your first MET call, and the one on the other side are those that are beyond 48 hours. And you can see that if you've had a MET call for desaturation, the earlier you have your second MET call, the more likely it is to be for desaturation as well. The further away you go from that first MET call, the less likely it's going to be for desaturation, and the more likely it's to be for something else. Okay? And that is the same for respiratory rate, and the same for sorry, too much. Don't go up a little bit. My apologies. There we go. For hypotension, the same for tachycardia, the same for seizures, the same for decreased GCS. And then you get to worried. So with a worried, if you had a MET call for a worried criteria, and then within the first 24 hours you have a MET call for another MET call, that trigger can be highly varied. It need not be worried again. And the further you go away from your first worried MET call, it doesn't change. The pattern seems pretty much the same. So you know, the sort of kind of signal that I'm kind of getting from that is that if you had a MET call for a physiological trigger, it puts you at risk of a shorter term MET call risk, and that's likely to be for the same trigger. But you've also got a longer term risk of having a MET call for another reason. So it just shows that there's a physiological vulnerability associated with these patients. So in summary, as I mentioned earlier on, MET calls are a clinical marker for short and long-term burden of illness. As a service, we've contributed to short and longer-term positive outcomes, probably through the reduction of multiple calls, improved outcomes at the at MET calls, and in combination that sort of reflected longer term with the improvement in hospital mortality, the better 12-month mortality, and the longer term mortality that we saw in those Kaplan-Meier curves. Organisationally, though, I think we've also contributed as an organisation. There's been some cultural shifts over that time period. Patient selection, I think, is one of those factors. The only data I have to support that is the reduction in the average age of the patients that are having MET calls. So I think we're selecting the home teams are selecting those patients prior to us seeing them, and the increase in the prior not for resuscitation orders that we're kind of seeing. And then the left on ward outcomes. Part of the MET team contributes to that outcome, but then it's the admitting teams though that sustain that outcome with respect to sort of the patients being left on ward. So I think over time we have borne quite a big burden, but there's been a cultural shift. I'm very confident of that. Where that burden now is starting to be better supported through by many elements through the organisation, and I think it's the bits that MET Service has done and the organisational changes that have occurred over that period of time that's been reflected in the short and longer term outcome benefits that we see with the data that I've presented. That's it. And a quick note, direct consumer escalation is up and running. That's the magic number that consumers have to dial over the next few weeks. It'll be you'll get to hear and see more and more of it. But just wanted to know finally we've got it up and running, and so we'll see and monitor and see how that evolves. Thank you.
Do we have any questions from the floor? If you've got questions online, you can type them in the chat as well. Rachel.
Yeah, Rachel.
Hi, thank you for the presentation. And it's more of a comment than a question to say that we really appreciate the services that you're providing our registrar. And I think having worked at lots of different hospitals, there's really very much the service here with the expertise that we have given people in responding to a deteriorating patient. Really notice it. It's fantastic.
Thank you. Yeah, look, I haven't talked about this, but big job of us as a service is to create some capacity. We've got about 32 general trainees that come through the MER service, spending a 3-month rotation. That creates a lot of capacity in terms of the building confidence and managing deteriorating patients in the wards. Other skills like ultrasound, cannulation of difficult IVs, some team leadership, working in MDTs, all of that has a long effect. So, very much so we're looking at building capacity.
It's a really interesting comment, actually, because Arthas has been focused on the education side of things, and I think there's been great concern around the fact that a MER service potentially de-skills a lot of your population, but we have seen with the MER RMO position that has been, as Arthas described, a very good training position that gives junior medical officers a very, very good grounding and increases their confidence in managing deterioration. So there's been great wins. Excellent.
And it's reflecting that organisational culture stuff that the data that we've shown. Yeah.
I'll just follow up on that. I wish that this job had existed back in several years. But I'm just wondering a bit more, what do you think has driven that shift left on ward? Do you think we're better at managing stuff on the ward now? Do you think there's reluctance in some settings for things to go off the ward given the demands of the system?
No, look, that's a good question. I think what are the demands of the system? The demands of the system here are where we can escalate to. Escalating to ICU, yeah, sure, there are restrictions there, but they're not manifestly prohibitive restrictions. I think more and more we'll see that we're also, I haven't shown the data here, but we are escalating to other places other than the ICU, and that's where we're encountering the resource limitations. So, thoracic medicine and AT are bearing more of our referrals, and cardiology as well. So, their services are already running on a thin line, and we're imposing a little bit more on them. So, I think that's where the capacity is. Going back onto it, I think we just referred to the legacy and the capacity that we're leaving with amongst junior staff. The follow-up aspect to the MER service, that's helped create a little bit of confidence, a bit of resilience with leaving patients on the ward. And the other thing that's been significant, and sort of some of the older people will be able to nod their heads to it, is the anecdotally, I strongly believe that there's greater engagement from the home team with the Met team nowadays. In the past, it used to be the other way around. Met wasn't very good at engaging with the home team. We've done a lot of work in terms of making, flipping that around. The little sort of illustration there I showed with Atlas in the hands holding up. I think absolutely that's been beneficial, and that has allowed more patients to stay on the ward and do that kind of things.
Campbell.
Lies behind that difference in the outcome, respiratory triggers, sensitivities.
Yeah.
I don't know. I would have thought hypertension and tachycardia is pretty bad physiology. I don't know. I honestly don't know. Yeah, but clearly, respiratory triggers.
That was exactly the question I was going to ask, and then I'm thinking back to a presentation around stroke where hypotension, which I thought would have really profoundly bad outcomes, didn't. So we always think of hypotension as a really dastardly sign, but maybe it's not the predictive physiological parameter that we place store on. So that's where data is so important, isn't it?
I'll dig a little bit deeper into it. Yeah, absolutely.
Yeah, I'll be surprised. So I did like the fact that you talked about repeat admissions and what we can be doing better. There is a great push around Carlin at the moment to make a 7-step pathway for everyone that comes through the door, which is pretty challenging because some people won't expect to be asked that question, and even some people that we expect should be asked that question get quite upset at the time. But often at the time of admission, there is some data that can help us make decisions. What additionally should we be doing at the time that we discuss the 7-step pathway with people now that we're currently probably not doing?
Look, based on what I presented, and I'll just remain focused on that. If you've had a MER call, a prior admission, that's a marker. And the data strongly supports that. We don't keep a very strong electronic record of that. To find out whether you had a MER call in the past, if it's not documented in your clinical summary, if it's not included in your past medical history, you've got to refer back to see if there's been a MER document to reflect that. What I do want to say is that when we do have our conversations with the patients about not for resuscitation, it's really important to not have the mindset that they're not for med side, right? Because 10% at 9 years, I don't think that's bad. It's not good, but it's not inconsequential. So if we frame our limitations of therapy discussion to you're not for anything, we're not going to be having very informative discussions with our patients.
So that's a really important point, because a lot of the drivers around this have been to say, well, you should either be for the whole thing or not for anything. But the data you've shown.
Yes. And now we're going into a new paradigm of the not for MER. So, quite often we will have these little discussions with the home teams where patients have got significant limitations of therapy. They're made for ward-based measures, and they have an episode of hypotension. For some of those patients, you can ask them, what can the MET team do for them that the home team can't do? For other patients, they absolutely need to have a more timely MET response. But for some of those, we may not be offering anything more than what the ward can. And so some of those patients will need to be not for MER, which now is a new language and new paradigm when it comes to MER. Hold on, 7-step pathway, you have to write that.
Steve.
Given that having MER calls a market, you able to estimate what percentage of any benefits MER possibly anticipated quickly after?
No, not really. I guess the only measure I have that is the shape of it.
We might know about how many.
No. So you have to do a match study for that, and that that can be difficult because the fact that you've had a MER indicates you've had an acute insult. If you haven't had a MER, you haven't had an acute insult. So it'll be difficult to do that match study.
Any other questions? Well, thanks very much, Arthas. MER is proving to be a very rich source of data and probably informs us very well about what effort we need to put in. Thanks.
Thanks, Joe. Thanks.